So I'll be going around the room. If we have any questions off the bat, I will come to you. So just raise your hand and make sure I can see it. So of course, I'm going to do the front and then I'll go to the very back after this.
Can one of you explain in very elementary language why it's so hard to find like a financial comparison between systems? And we hear it, I think Mr. Janda mentioned the $32 trillion figure. We hear that number all the time. But then you see other projections that show that costs in the long term would possibly go down in the Medicare for All system. Is it that we don't know how the system's going to react to a Medicare for All, or what is the simple answer to why you can't find good financial comparisons?
I mean, the analysis the various ones that are up there are actually very good, solid economic analysis that you can go to and see how they did that. And it's basically taking, projected utilization and the number of people and payment rates for different services and subtracting and adding to them. So they're all very sophisticated. They use different assumptions, which is why you get the different numbers. But, I've not seen any credible analysis, and those that I use I actually stole from Vivian Ho at Rice and the Baker Institute. So it's like tested by real solid academic research that these are all pretty expensive. What doesn't point out there is that, some comments were made about this, is that you have to subtract out what employers are paying right now. So a lot of those analyses are net of that, and some of that is hard to tweeze out exactly how much employers are paying because they're self-funded and we kind of know what we think they're paying, but it is complicated. But the way I think about it is, as an insurance guy, in the insurance world, 85% of the cost is medical claims, okay? The premium that you pay, and that's price times volume. How many MRIs you do times how much you pay for an MRI, right? So you have to always be thinking, no matter how you look at it, is how many doctor's visits times how much you pay, how many hospitalizations times how much you pay, right? And so you have to look at these systems by both price that you pay and volume. And what I worry about with the Medicare for All is that the talk that Senator Sanders and others have is about price. Well, we can get a better price. We can get a volume price from the pharmaceutical manufacturers. Maybe you can, but he doesn't talk at all about utilization of services and which services really matter. And there's a number of studies that suggest that about 30% of all the medical care provided in the United States is of zero value or negative value in terms of actually improving outcomes. And so I know insurance companies get a lot of grief for this, but the reality is part of what insurance companies do is they lean on the system to say, do you really need those services? Or that's why they get pre-authorizations and all those kind of things, generally because they're services that are suspect in terms of whether or not they do any good. The administrative expense, no doubt there would be administrative expense savings. And so that net cost of $32 trillion or whatever does assume a pretty significant reduction in administrative expense. But the reduction in administrative expense happens one time, right? So you have to think about medical costs increasing over a 10-year or 20-year period. One time, you might take out 5% of the cost out of the whole system and reduce the administrative expense. But then, the next year, as prices go back up, it doesn't take but a couple of years for that 5% one-time dip to be eclipsed by the continued increase in cost. And so you have to, what we really have to be talking about, if we're worried about cost, is what is the best system to, what we call in the business, bend trend, to reduce the rate of increase in total cost. And you can't do it on just saying you're going to eliminate the insurance companies. Now, if you wanted to say you wanted to eliminate the insurance companies, and you also wanted to have the government take over the pharmaceutical industry, where the profits are much higher than they are in the health insurance industry, and the executive compensation is even more ludicrous. And not that there's not problems in the health insurance industry, right? But you got to look at the whole business if you really want to save money. And we have to I mean, my discussion about the 4 bases is really serious. We have to figure out how to get everybody covered. We have to figure out how to do administrative simplification and not have all this complexity that we have. And we have to figure out how to slow down the rate of increase. And so if you do, we need to be talking about what are the best options for doing those 3 things rather than jumping to a solution all one time and saying, oh, well, this is the solution. Because I'm not sure everybody agrees with me that those are the 3 things. Generally, I get a lot of positive response to that, but it's not the only part of it. That was way too long.
I'd like to add one thing. I'd just like to add one thing to that is the lack of data and transparency. I think that's why no one can give you a straight answer. Just to give you an example, I mean, if you go out of the hospital and see your bill and you say, how did you come up with this $50 Tylenol? There's really no one in the hospital who can tell you. It's so complex how different hospitals, how different healthcare providers, how different insurance agencies, they all have different ways of coming up with what something costs. That's why I think this legislation that's going through now that's kind of like forcing insurance companies and hospitals to actually tell people how they come up with their charges is a very important first step. You have to have data. If you don't have data and someone who's going to share it with you, well, you're not going to be able to come up with these exact answers. So to a certain degree, we are kind of guessing with whatever reports we get, whatever information we do get out of the healthcare system. And since everybody's different, it's hard to put it like in one, one formula and say it's going to equals X, right? That's been very difficult.
I'll stay on this question. Thanks so much for coming out. Very informative talk. My question is, with our current political landscape, how feasible would it be to pass and implement Medicare for all, for example, with the Republican-controlled Senate?
I think the question is, it's a valid one. I think it'd be pretty difficult. I think you think about all the different contingencies and all this sort of different stakeholders. So we talked about the health insurance industry, we talked about physicians, we talked about hospitals, and all of those major organizations, at least the ones that are lobbying now, being against Medicare for all. I think it's going to be difficult because obviously there's a lot of money at risk here for a lot of organizations, institutions, and enterprises. And so I think if you just take the lobbying impact itself, it's going to be pretty difficult. And then if you even think about back to the Affordable Care Act, there are some people on the far, far left who say that's a bad legislation. There are people in the middle who say, hey, it's decent, let's keep working on it. Then there are people on the far right who say, it's horrible, let's go back to everything we used to have. So even in sort of basic issues, Congress can't agree. So imagine now, superimposing Medicare for all, and then all the lobbyists that are in play as well, how that's going to work in terms of just Congress. And I think just in general, we're at a very charged, polarized time in our country as far as politics go. So I think just you see it every day on the news, how people just diverge in terms of their opinions just based on political lines. So I think it'll be hard.
Impossible.
Thank you.
Because even if the Democrats flip the Senate in 2020 and there's a Democratic president, if Bernie Sanders is elected president and there's a Democratic Senate and a Democratic House, you still will have not have the political will to go this far. I don't mean that because I have a vested interest in it not happening. I mean, I think we need to have the debate about it. But the political reality is that there are still going to be huge problems in different states, and and you can't underestimate the power of the lobby against this. You didn't mention pharma. In the first quarter, we haven't seen the second quarter yet. The first quarter of this year, the pharmaceutical manufacturers' lobbying expense was more than double the rest of the industries together, the rest of the healthcare industry. And that's not because the health insurance companies, the doctors, and the hospitals haven't also been lobbying, but it was like, I want to say, $6 million a month or something like that they're spending on this. Pharma does not want this to happen. And I wish we could have an honest discussion about it, but I think realistically the best that we're going to be able to do is to make some improvements in the Affordable Care Act. But I think if we get to universal coverage and we can have an agreement in the country that we have universal coverage, then we start picking away at how do you get from second base to third base, and how do you get to what do we need to do to simplify the administration? What do we need to do to slow trends in costs? And so I look at it as an incremental process, and I think that's really the most realistic thing that could happen over time.
I don't think politics is really the answer. Once we start talking about Republicans and Democrats, you're kind of like lost, because each one is going to start pitching against the other. I really think this is, the issue is going to be solved with people talking to people, because there's a lot of misunderstanding. And that's why I'm so glad that Doctors for Change invited us to speak finally. And because that's the way things happen, because you have to talk to people, in the street, in the classroom, in the doctor's office. You go to a doctor visit, I pass them a brochure, Physicians for All, So absolutely, I think we have to talk to each other and not depend on our elected officials to get us out of this particular issue.
Great. Raise your hands just so I'll be slowly making my way to as many people as possible. And also, we're handing out a advocacy action plan, so we'd love you to fill this out. And then if you want to get involved with DFC, you put your information on the bottom, and we'll reach out to you.
So I'm glad you mentioned earlier moral hazard, and you said that the pharmaceutical companies weren't incentivized to addressing this problem. 17%, 19% of our GDP is going to healthcare, which is our physicians, insurance, pharmaceuticals, and there's a moral hazard there, right? They don't really want to solve this problem. So what's your justification for having the providers and the insurance companies at the table to a solution if they're not really bearing the brunt of the cost?
Well, I just think when you're talking about trying to get something done, you have to have everyone at the table, because these are going to be, in some ways, these are people who are putting into the system, but they're also going to be the end users. So I don't think it's possible to really exclude them. And again, there are powerful lobby, pharma, physicians, insurance companies. And so, and I understand what you're saying in terms of, from a purist standpoint, what they're invested in may go counter to maybe what other people want. But I just think at the end of the day, it's not feasible to exclude them in that way.
Well, I also think that we have a whole country that's built on spending all this money. So there's all of us who have 401k plans need the stock in our pharmaceutical manufacturers that are in our 401k plans to not tank, and the insurance companies and the for-profit hospitals out there. So we have a for-profit system. To try to take that all away in one step is pretty hard. So, clearly the insurance companies are not particularly a loved industry, and so it's easy for Senator Sanders and Elizabeth Warren to sort of say, yeah, just get rid of that entire industry. But I just don't think that that's very realistic. And I would still go. I'm gonna keep harping on. I call it running the four bases, but I think every one of you needs your own rubric of what is it that what are our goals? Don't say what the solution is. Say, what is the goals? Do we want healthcare to be 15% of GDP? How do we get to be 15% rather than 19%? Or do we want it to be 10%? And okay, if you want that, then how many jobs is that? How many people's loss of income is that? Where does that loss of income come? What are we going to do with the money instead? I mean, I've heard people argue this, like, what are we going to do? Buy more iPhones with all that savings? Now, if we invested in education and housing for low-income people, maybe I could change my definition of how much GDP. But I think we have to, us in this room and all of us talk about is what do we want to do? I think, I keep coming back to, we should cover everybody somehow. we should reduce the rate of increase in cost. And if we could hold cost flat for 20 years, every year it would be a smaller and smaller percentage of GDP. That's what we should be talking about doing, not grabbing money from some industry right now, but how do we have zero trend for the next 20 years or something like that? And how do we make it administratively easier for doctors, for patients, for everybody that uses the system? And if we keep sort of focus on those things, I think we can then evaluate lots of different options and say, okay, yes, Medicare for all would do this, but at the risk that Jane talked about earlier.
Medicare for all, solves all those problems. But I will say, going back to the,
I guarantee that Medicare for all would cause an increase in utilization that Jane talked about.
Well, one of the good things about being a country that comes in dead last as far as coming around to single payer is that we can learn from other countries. And these doomsday predictions happened in Canada, happened in Norway, happened in Singapore, happened in Japan. They happened because of course, the need for keeping your profit is extremely strong. You're talking about people's livelihoods, right, at the level that they would like to have them, and we're no one to take that away. But a lot of these predictions did not come true. Utilization did not go up. It went up a little bit in Canada for a little while and then came back down. And here, utilization tends to go up when people get on insurance anyway, because you're going to have a lot of people getting on insurance for the first time in a long time. Of course, utilization is going to go up a little bit for a little while. But that does, in other countries, that tended to go on. So I think we can actually, make that change over by learning from the mistakes of other countries. And I know at the School of Public Health, we're constantly having visiting professors from those countries teach us not what they've done right, but also what they've done wrong and wish that they could change. In Canada, they're having debates right now. Their #1 debate is on their healthcare system because they would like it to be better because they don't cover dental, they don't cover eye exams, and they don't cover mental health the way they should, and they don't cover drugs when you leave the hospital. So there's still people paying out of pocket. So we're not saying, let's move to Canada, it's perfect. It's not perfect. But I think by learning from other countries, we can make something better than what we have right now.
I vote Switzerland.
I just want to add one more thing, because I think there are two issues. I think one is the goal, and then the second one is the strategy. And for the strategy component of things, you can't take the politics out of it. And I don't mean to be cynical, but I think that's true. You cannot take the politics out of it. So when you're thinking about your strategy, you have to think about what is that end goal and how do we get there? Is it just a bold move in 4 years? Is that really feasible with all the opposition out there? Or is it what you talked about, Ken, in terms of being sort of incremental change? And I know people don't like to hear that, but again, that becomes the strategy, understanding there is a political environment and there's so many stakeholders at play. So I think sometimes when we think about these policy and advocacy issues, we try to divorce the two, but you just can't. So strategy becomes even more important.
Hello. So in keeping in line with strategy and sort of incremental change, the other big proposition in addition to Medicare for All is a public option. And I was wondering what you all thought about the financial and political viability of a public option, considering that the arguments for it are often that it utilizes free market forces to perhaps get us to Medicare for All, or not, we can stick with it, and also it might be a little bit more politically palatable, as well as allowing the federal government to sort of build the systems naturally that would allow it to take on a system like Medicare for All.
Yeah, I'm not sure what a public option means, okay? You just can sign up for Medicare, is that the public option? Yeah. Or you can, right? But, Medicare, the administrative side of Medicare is based on your Social Security status, and so there would have to be a whole new infrastructure built for people under age 65. So it's not just free, right? It's not just Medicare for whoever wants it. I think Right. And the question is, so you would say that the government is going to compete against the insurance companies, right? So we have that right now in the Medicare space, right? That's Medicare versus Medicare Advantage. Medicare Advantage is winning. Just to be honest with you, if you look, the rate of increase every year is going to be 40% probably next year, and every year more and more people are doing that because they're saying, okay, they provide value-added services, they reduce the deductibles, they do other kind of things. I love Medicare Advantage actually because it says everybody has this base level of coverage, which is the standard Medicare coverage, but then you can do other things to make it more attractive to people. So as a former insurance executive, fine, put a public option in there. I'm not afraid to compete against the public option because we know how to compete against the public option already in the Medicare space. I don't think it matters one way or the other. And to me, it adds another level of complexity. And I'm looking for how do we reduce the complexity right now, not add more complexity to the system.
But I do think, to part of your point, I think from a political standpoint, I think that's why some of the candidates are heading towards the public option, because I think with the whole debate about the Affordable Care Act, one of the issues on the table back then was putting in a public option. So it's not a new concept. And so I think people have in their heads historically from when that happened. So now to hear it again, it's like, oh, okay, maybe we could actually do this. And so I think it's two issues. I think it's one is, does it do anything and can it truly be competitive? And the other part of it is, it's something that people may be more likely to accept for the reasons that you stated.
So with public option, it sounds great, and it's like Medicaid expansion, but one of the things that those two things don't deal with, again, is cost. So someone still has to administrate it, it's going to cost, so it does nothing to kind of like bring the costs down unless you get enough people that you're able to negotiate. I don't think that's going to happen.
Yes, my name is Ira with MedicareForAll.us, US meaning us, all of us. And you'll find a good summary of why we need Medicare for All at that website. Mr. Janda, I want to give you a free advertisement. All the points you're saying, almost verbatim, can be found at the website of the Partnership for America's Healthcare Future. It's the main front group, the main industry group of insurance companies, which I'm sure you're familiar with. You're probably familiar with the site.
Yes.
Right. All of the arguments you made, if anybody wants to review them, can be found at that website. And it's backed by millions and millions of dollars of all the industry groups that want to kill Medicare for all. So that's the view that you will get from there, and that's what we heard tonight.
I just defend myself a little bit. I mean, I actually do agree with a lot of what they put on that site, but that's not to say that we shouldn't be looking for how for-profit insurance executives should make less money, just as the for-profit pharmaceutical manufacturers and executives should make money. We should look for simplification that a lot of the insurance industry doesn't want to do. We should look for other ways of financing things. So the reality is I spent 38 years in that industry, so I agree with a lot of it.
Okay. Well,
but not all of it.
So all I would ask us in the audience is, when you hear information like that, is consider the source. So that's that. Thank you. I'm sorry, I forgot your name. Yeah.
Rosalia.
Rosalia. That's right. I've seen your name because I've done some work with healthcare for all Texas. With Pat. I'm sorry, with Peg. Last week, I had the pleasure of chatting with a UNESCO bioethics expert by the name of Alberto Garcia. He's based in the Vatican. I know him. Down to Earth guy. And he said that health justice is one of the three leading challenges that the world faces today in bioethics. And what we're facing now with Medicare for All is the opportunity to make a huge stride in health justice in the United States. I asked Alberto if he'd had any experience with the Italian healthcare system. It's a single-payer system, of course, they all are, except ours. And he said that, yeah, he was in the hospital last year. He was in the hospital for several days. And when they released him, he said, there's no paperwork, there's no bills. Just walked away. That was it. He was done. That's what 330 million people in the United States could experience with Medicare for All. There's more, but I'll get off my soapbox. Thank you.
I think we have a question.
I do have to make a technical correction. Switzerland has a private insurance system, Belgium has a private insurance system, Germany has a private insurance system. So it's not every other country that has a single payer, just to be clear. Now there are, all those countries have a requirement that you have health insurance. And in many cases where there is a government-run plan, there's private insurance that's on top of it. So you could still have a Medicare supplement. So yes, the United States is unique in that we have, of all the industrialized countries, we do the crappiest job of covering people. But
And spend the most.
and spend the most. Yeah, not doing it very well, right? So I agree with we need to look for changes.
And thank you for that comment. And I will have to say, I'm a little embarrassed that, I came up here and I really tried my best to make some logical economic arguments and did not touch on, or didn't want to touch on just the morality of the issue. And I have to say that I was just a little insulted when I saw that one of the arguments that physicians would have less incentive to care for their patients because they were making less money. I just, unless y'all are lying, I've never heard a physician say, I got into this because I'm going to get rich, right? So I really believe deep down physicians and all healthcare providers of every walk really want to help people, humanity, and that I stood up here this long and did not mention the moral premises of having health care for everybody was remiss on my part.
It's stunning to me that when I talk about morality, because I do when I'm in Austin, Washington, that's not politically
Correct.
It's like, what are you talking about? It's like, somehow they will magically get access to care. They don't have to have insurance or Medicare for all. It's just magic.
Okay, assuming we have a single payer system, and I wanted to thank you, by the way, for mentioning the whole issues with the disabled, because those were some issues I hadn't considered before. But assuming we have a single payer system, what is to keep the government from using this as a for-profit basis? That's our problem now, is that we have all the for-profit organizations. So, do you foresee that being an issue? No one's mentioned anything about it, but I could see the government using this as a for-profit.
Well, Kevin Brady, one of those congressmen from here in Houston, said yes, we could be the federal government could be the largest insurance company in the world, and it has its own army. And is that what we want? Is that the government role to be a giant insurance company? And actually, at some level, the United States government is already the largest insurance company out there. If you look at it from a financing standpoint, I think that you mentioned, or one of you mentioned it, when you add up how much the government pays for Medicare, Medicaid, the state workers, the federal workers, the people that work for the school districts, all the tax dollars are already paying a whole big chunk of the expenses. So we shouldn't kid ourselves that the federal government needs to do a better job, and also part of that administrative expense savings needs to be less fragmentation in the way it's financed. But the difference between talking about financing of the system versus how you deliver it. Because we haven't talked about the fact that we really should switch to the British system, and all of you need to be government employees, right? And work for the National Health Service. Why, I mean, you know, yeah, but my point is there's other models as well, and so it is interesting model that says it's the insurance companies that are the problem, as opposed to the reality is it's all of us. We're all part of the problem.
It would be great if the government could make a profit on anything. I think right now they're just spending a lot of money and not having a lot to show for it. So we should be the healthiest people in the world. No one should have diabetes, no one, should have asthma, no one, so if they were to actually go after making a profit, that means that really all of us would benefit from that, because that means that they're controlling costs and getting people in to see the doctor, and so that'd be great. But I don't think the government's made a profit in much. But if they could just spend less money, that would be great.
Oh, final question.
First of all, I comment to Rosalia, and you said that other countries show an initial increase of usage and then the usage goes down. Hopefully that's because people are actually getting healthier and needing less usage, so that's just the comment there. The thing I really wondered, Ken, from the beginning is you mentioned that there would be a savings on Medicare and CHIP and some of those other programs. Does anybody have numbers on those? And I see it as a conundrum in the whole political aspect of this and the phasing in aspect, because those seem to be the things that should go first, and yet they're going to be the hardest sell. But do you have numbers? Numbers on Medicare, the savings if we eliminate Medicaid and CHIP and other.
Well, the problem is there's not a savings on Medicaid, because then you pay doctors more for Medicaid in hospitals. So actually the cost of Medicaid may actually go up because of a higher reimbursement rate for services, because Medicaid tends to pay about 70% of what Medicare pays.
Why would there be a difference? And there wouldn't be a Medicaid anymore.
No, I'm saying if you're talking about the numbers and making the numbers work, you have to add, part of the additional cost in the system is eliminating Medicaid costs money, because you assume that doctors and hospitals get paid more, but they get paid less on the commercial side that they're getting right now. Again, I didn't bring any of the analysis with me, so I can't do them off the top of my head, but these economic analysis did a really good job of here's the additional cost, here's where the savings come from, and you can actually, there's several of them. I know the last one from the guy at Emory, whose name is escaping me right now, that only says 25 trillion, does a really good job of sort of summarizing where the additional costs are, where the savings
And that includes
come
the
from.
administration and process.
Yes, no, all of them assume administrative savings. There's no doubt that there's administrative savings, and we should be looking for ways to do administrative savings, absolutely. I can get the sites for all 4 or 5 of those studies that I sent up there. I didn't leave them on the slide because it gets really cluttered to have all the citations on there, but I can send those.
We can get the slides up. All right, well, thank you everyone for a robust discussion. If the speakers wouldn't mind staying up here for a few minutes, if other people have questions. Round of applause for everyone. Thank you all. And real quick before everyone leaves, we had